catalyst, contact lens education, etc. Over to you, sir.
Thank you, Garvita. Thank you very much for the elaborate introduction. Thank you. Well, I'd like to welcome Dr. Prafull, who will be the speaker for today's class. Dr. Prafull has done his senior residency and post-graduation from Dr. RP Center of Ophthalmic Sciences in Delhi. And now he's serving as a faculty there. Of course, he is a well-known national faculty, and we are very happy to have him here for the class today. Welcome, Dr. Prafull.
Thank you. Good evening, everyone.
Yeah, hi. And I also welcome the chairperson for today's class, Dr. Bhupesh. Dr. Bhupesh is an army man from Armed Force Medical College, and also he's done his fellowship in Corneal from PGI Chandigarh. And I'm sure he will add a lot of value to the discussion today. Welcome, sir. And I thank both the dignitaries to take out time for us at 8 o'clock in the night and teach all the postgraduate students. Thank you. So over to Dr. Prafull today.
Garvita, my PPT is visible, right?
Yes.
Yes, sir.
See, good evening, everyone, and to all my students. So today's topic is combined cataract extraction and cornea transplantation. And I think this is the cataract module going on. So my focus will be primarily on cataract surgery and the other complications that can occur when you are doing cornea transplantation with cataract surgery. So classically, this is called as triple procedure. So nowadays, since the advent of DSEC, DMEC, the triple procedure can be with DALC also. But history-wise, if any examiner asks you what is a triple procedure, so this is what a triple procedure is. And I think the first paper came in 1987 when you combine full thickness corneal transplantation with cataract extraction and intraocular implantation, then we term it as triple procedure. So today my discussion will be largely on this only because this is what often asked in PG exams. So when we are discussing with triple procedure, so these are the three issues that should come into your mind. First, since you have to put an IOL and you have a corneal opacity, so what are the problems that can be there in IOL? But I guess there was a class about IOL power calculation in special situation by Dr. Manpreet Kaur. So I'll not go into the details of this. I'll just touch upon few important points. The second, surgery related. So this is probably a biggest concern when you're combining PKP with cataract surgery because conventionally phaco, ECC, these are all closed chamber procedure. But when you're combining cataract with a procedure like penetrating keratoplasty, it becomes an open chamber, open sky procedure. So there are challenges that I'll discuss intraoperatively during surgery-related issues. Post-op management, well, it is similar to a routine cornea transplant procedure. However, there are some issues which I will discuss subsequently. Lastly, patient, because somebody can do a stage procedure, first a PKP, then cataract, or somebody can do a cataract, then PKP, or somebody can combine and do a triple procedure. Now, from patient perspective, it is important to know why to go for triple. Why can't somebody go for a stage procedure? So I'll go through this one by one. So first is IOL power calculation. As I said, there was a lecture about IOL power calculation in special situations. So I'm not going to details of this. However, remember there are two issues. For any biometry, you need an axial length, you need a keratometer. So axial length reading, either you have ultrasonic or you have optical biometry with you. Now, when optical biometry comes, when the optical biometry is concerned, since there is a corneal opacity, and if it is a completely opaque cornea, so it's unlikely that any ray of light will pass through. So optical biometry, although it is more accurate than ultrasonic, but it's a limited thing in cases of keratoplasty with cataract because of the corneal age. However, if it is possible, then it will give you accurate result, especially the IOL Master 700, where the principle is based on swept source velocity. The second, ultrasonic, yes, ultrasonic is the gold standard. But there are some issues with ultrasonic axial length measurement when there is associated corneal opacity. First is patient fixation. If you have done the axial length measurement in ultrasonic, you must have seen the examiner shows a thumbs and then ask the patient to fix on that. But when somebody is having cataract as well as corneal opacity, it is nearly impossible for the patient to fix it. Okay, so the axis that you are measuring may not be the exact axial length of the patient's eye. Second, cornea is thinned out. You know, ultrasonic has a problem of indentation. When you're pressing the probe, you may be indenting the cornea. And when the cornea is thinning, this may be more. And also the cornea may be uneven. So all these things can lead to errors in axial length measurement in ultrasonic biometer. If you have immersion technique, I hope you know what is immersion technique, then that is better than ultrasonic technique, where you use a water bath and do that. So all this indentation, all this factor is not there. However, fixation issues will still be there. Then always consider the other eye. Why I have written this? For example, if the patient is wearing spectacle of similar power, of the patient knows his past history of spectacle power or vision, if both eyes were vision 6/6 without any need for glasses, then most likely he may have an axial length which is comparable to the other eye. So you should always compare the axial length that whatever you have got with ultrasonic with the other eye. So this is just brief of that. Details I think you have been taught in that special IL biometry class. Now, when keratometry is there, again, there is corneal opacity, cornea is irregular, anything which is tomography based, like Cirrus or maybe pentagram, or if you don't have that, if you have off scan, then they will give you good values of that. When you are using pentagram, because at RP center we do have pentagram only, there is something called equivalent K reading, and there is something called true net power. You can use either of them. However, if you don't have a tomography, but you have a good biometric like Lenstar or IL 700, then also you can use the reading of those equipment. But you have to remember all these factors still may not work, right? And these are the machine based. One is surgeon. The other thing that one can do is surgeon based. For example, if I have done 100 keratoplasties and I know that my post of cornea K is going to be -1 diopter tip. So in those cases, the surgeon may use his past data with a nomogram, which we called as a regression formula, and then he can plan. If my average keratometry following PKP is 45.5, then I'll take a 45.5 because anyway I'm going to change the cornea of the patient with the donor cornea. So that is another method. Okay. And few surgeons, what they do, they don't rely on history or their past record. They simply go with the standard K, which is 43.5. So you have all these three options of of choosing which keratometry to be used. So this is brief about axial length and keratometry. So this is how you should manage. Now the second issue, as I said, surgical issue, pre-op measurement, pre-op measures, right? So all open sky procedure, the single most factor that keeps on bothering you throughout the procedure is positive vitreous pressure. Since you have removed the cornea, this is open sky, there is nothing to push the vitreous behind. So vitreous have a tendency to come out, right? So how to tackle that? Well, there are several measures that you can take. Intravenous mannitol, you all know mannitol. Dose 0.5 ml per kg, that is the simplest if you are using a 20% solution. 0.5 ml per kg body weight. Timing, remember the maximum effect of mannitol comes around 30 to 45 minutes. So you have to time that. It shouldn't be like in the morning you have given mannitol and you are operating in the evening. Especially in high volume centers, this may be an issue. But if you are only doing keratoplasty, no other procedure, then plan your surgery in such a way that the moment mannitol is over, you should you should start suturing within 45 minutes of that. That should be your target. Mechanism, you all know. Mannitol, what it does is contract the vitreous. So that is the most likely mechanism how it acts in open sky procedure. So mannitol in exam, they may ask you what is the dose, when should you give, and what is the mechanism. And one practical issue which may be asked you in Viva is, if you have given mannitol, if you have blocked the patient, always take the patient to your washroom. Because mannitol, you know, it's a diuretic and triple procedure may take 1 to 1.5 hours. It's a long time, right? So in between, the patient may become uncomfortable. To avoid that, always take the patient to washroom before shifting onto the table. The other procedure is super pinky ball. Recently, there is a lot of controversy. Few people believe it doesn't work at all. But at RP center, routinely, if you are doing a keratoplasty, we are using it, we using peribulbar block, and we have at least 8 to 10 minutes of super pinky ball there. How it acts is it distributes your, not only it distributes your xylocaine and bupivacaine, also it brings some sort of hypotonia. So that is also another measure that you should practice. Third is anesthesia. Nowadays the anesthesia doesn't have that problem because most of the center they are using sevoflurane. But when ketamine used to be used as an anesthesia, ketamine is known to cause raised intraocular pressure. So when you're giving general anesthesia, you have to discuss with the anesthetist that these are the anesthetic agents that can raise my intraocular pressure. So you have to avoid those anesthetic agents. And even there are few papers that suggest that peribulbar anesthesia is better than general anesthesia. Because in peribulbar anesthesia, you can use super pinky, you can use digital massage, and you can reduce the vitreous pressure. But in general anesthesia, you're not giving peribulbar block, neither you're applying any massage. So eyeball pressure is almost equal, or maybe because it may become little raised because of the anesthesia impact. Now, second important point pre-op period is you have to inform your assistant to dilate the pupil because it's a triple procedure. You not only have to remove the cornea, you have to remove the cataract also. And generally, when you are doing PKP, you don't dilate the pupil. So your assistant or the resident who is working, they may forget to dilate because their viewpoint is that it's a penetrating keratoplasty. So pupillary dilatation doesn't matter at all. So pupillary dilatation also you should keep in mind before going for your triple procedure. So this is a video that I'll show and I'll discuss the few salient points while showing this video of cataract surgery in an open sky procedure. This is the video from my SR, Dr. Vishal Kumar. He's an excellent surgeon. And so first is corneal marking. This is what my assistant is doing is like measuring the corneal diameter as well the extent of the corneal opacity. Now remember, when you are planning triple procedure, you have to do all the steps fast. Okay, you don't have enough time. Now, first thing is few surgeons what they believe you should do a paracentesis. Why? Because if you do a paracentesis, it lowers the intraocular pressure. You know, the biggest problem or biggest threat a surgeon feel when doing open sky procedure is suprachoroidal hemorrhage. Suprachoroidal hemorrhage, one of the most important factor is sudden decompression of the eyeball. So if you do a paracentesis at the beginning, then it may not allow the globe to decompress suddenly. There may be gradual IOP lowering, which may prevent suprachoroidal hemorrhage. Now, few surgeons, they use this RK marker. So I don't use it, but if you are starting the surgery, you are the beginner, then you should always go for that. Now, trephine. So vacuum trephine, see, you all know there are two types of trephine. This is a manual trephine that is being used here. And the other trephine is vacuum trephine. Now, the problem with manual trephine is if you don't have enough expertise, so you can go full thickness trephination. But if you have a vacuum trephine, if you remember Hesburg-Baron trephine, for every full rotation, it cuts almost 263 multiplied by 4. So 242 around, 232 around it cuts. So if you know how much depth you are cutting, then you will avoid a full thickness cut through. If you are not that much experienced and you are using a manual trephine like this, it may happen that you may land up in a full thickness trephination. Now the problem of full thickness trephination is, again, there will be sudden hypotonia. And we don't want to do that. If you do that, then there is a risk of suprachoroidal hemorrhage. So always go for a partial trephination and then go for a full thickness trephination. And when you're dealing with corneal opacity like this, and few surgeons what they believe, first you should do a lamellar dissection, you debug the cornea and then see what is there in the antechamber, and then you make the final full thickness cut. So here it was a partial thickness trephination was done. You can see here. Right, so then you can inject some Hilon through the side port, so the chamber is formed, and then you can take either a 15-degree knife or a MVR knife, and then you make a full thickness entry here. As you can see, the Hilon came out immediately. Now here it is important to note that when you have already opened your eye, then the rest of the maneuver has to be very fast, because the more the time you give the eye to stay in a state of hypotony, the more is the risk of suprachoroidal hemorrhage. So you can use your right-handed and left-handed corneal scissor In between, try to inject some viscoelastic and form the angle so that the globe is not hypotonous. So you keep on injecting some Hilon or some viscoelastic and you continue your dissection. But this, I have slowed it down a little bit so that you will understand. But this has to be fast. You cannot waste so much time into this dissection. Okay, once if you are using, if you are not sure about the diagnosis of your keratitis or corneal opacity, you can send this button for histopathology. Now you can see the cataract here. It's a hard cataract with some fibrosis of anterior capsule. Now it's an open sky cataract surgery, right? You don't have a anterior chamber. You don't have a closed anterior chamber like in FECO or ECC. So everything you have to remember will have a tendency to come out. Okay. So this procedure again, here capsule was not stained, but ideally for all triples procedure, you should stain the capsule with trypan blue because that will give you better visibility, especially when doing the rhexis part. Once you raise a flap, it's always to use a rhexis forceps because that will save a lot of time. Here, intravitreal or micro rhexis forceps is being used. This is also good enough. You can use that. But remember, you can see here, there is a little bit struggle in identifying the edge. So that's where the role of trypan blue comes. If you would have used trypan blue, then it would have given a better visibility. So as you can see here, once the surgeon is not sure about the rhexis edges, then immediately it was converted into capsulotomy. Multiple tomy incision are given, capsulotomy was done, and almost 5 to 6 mm rhexis was achieved. Now there are several ways. This is a way you can tumble the nucleus out. I prefer to inject some BSS behind the capsule so that nucleus tumbles out. So immediately after that, you can do some visco expression of the cortical matter. As you can see here, as it was a hard cataract, there was not much cortical matter here. The entire nucleus came out. Always put a 3-piece IOL if you're not sure about the your rhexis, because in this case, in this patient, the capsulotomy was done towards the end, right? So the IOL should have been placed in sulcus. Luckily, in this patient, you can see the iris is good enough and it is almost equal size of that the optic size. But there are several cases where you'll find the pupil is almost 8 mm atrophic, especially in cases of viral keratouveitis. In those cases, it's always good to do a pupilloplasty because you need a 3 to 4 mm pupil, or else the IOL will continuously popping out of the sulcus. Now, once this is done, then almost your one part is done, cataract and IOL implantation. So 2 out of the 3 procedure has been done. And rest of the keratoplasty is like simple suturing. But remember, you have to do a little bit faster. You don't have time. At least put the 6 suture immediately, and then after that you can take your time and do all this maneuvers. Yes, this is what is a triple procedure with full thickness corneal graft, penetrating keratoplasty, where you are doing a open sky cataract surgery. Now with time we have, now this is the era of endothelial keratoplasty. This is one of my video of dissect triple procedure. It was a case of keratouveitis. As you can see here, there was a disc scar inferiorly with a hypertrophied epithelium. You can see the scar is here, and this was the hypertrophied epithelium. So to improve visibility, I am removing that epithelium, which was hypertrophied. Now here I will tell you few tricks to how to do a cataract surgery when corneal opacity is there. There is a paper by us from a group from RP Center in JCRS. You can go through that, cataract surgery in corneal opacities. But these are the tricks. Here the patient was a little bit uncooperative, so I had to use little bit subtendon anesthesia. Well, this is not the cannula that should be used, but this was the only option available to me. So I injected some anesthesia into the subtendon space. Now you can see visibility is not that good. Okay, so as you can see, it was a central haze here, but you could see a lot of DM pores suggestive of some sort of endothelitis maybe. And it was a the cataract was NS nucleus is grade 2 to 3. So we thought of going for a dissect triple procedure here. So I'm doing my standard cataract surgery. Few surgeons, when they are combining dissect with cataract, they prefer a corneal scleral tunnel. But I'm not comfortable with scleral tunnel phaco, especially when the media is haze and the conditions are difficult. So I would prefer to go with my usual technique. So it was a clear corneal incision only, a little bit towards the limbus, then standard 3-port, then viscoelastic. And in all these cases, you have to stay in the capsule. You know, like that open sky, the capsule was not stained, but somehow it could be managed. But here you have to stay in the capsule. And the initial you should raise with a chesty tone or whatever device you are comfortable with. But remember, the completion of access is always with the capsular access forceps. Why? Because gauge you have to repeatedly grasp and regrasp. But here it's once you catch hold the capsule, you can have this, you can move it 360 degree and your access is done. Right. And next step is hydrodissection. Hydrodissection is very important in such patients because you have to continuously rotate the nucleus, bring it to the area where it is little bit clear. Here you can see this area is clear little bit, right? So all my chopping maneuver I'll have to do here. So I need a good hydrodissection so that I keep on bringing my nucleus here so that I can divide it. However, in the video, even some visibility is there, but while operating, it was a nightmare for me, and I was really very much worried what is going to happen to the nucleus. But somehow these cases, you are not bothered about endothelium, so you can do a little bit anterior phaco, and you are not bothered about causing a PC defect. If you land up in a PC defect, then it's going to be a very challenging one. You can see here by repeated attempts, 3-4 attempts, I could divide the peripheral cortex, and this is the central hard part. Then this can also be divided subsequently, and then the phacoemulsification was done. The key here is I'll always stay in the capsule and try to do all the chopping, all the maneuver. It has to be done in the clearer area of your cornea, not below the opacified cornea, right? If visibility is extremely poor, you can use chandelier illumination. You can switch off the lights of the OT, right? You can use a full coaxial. Here you can see there are 3 dots. So I'm doing a mixture of diffuse plus coaxial illumination. When there are 3 dots only on the surface of cornea, then that means you are completely doing a coaxial phacoemulsification. That would also help you in presence of corneal opacity. And always remember one thing: viscoelastic transiently give you some magnification as well as improves visibility. So whenever you are feeling that cornea is getting dry, ask your assistant to keep on putting the viscoelastic on the corneal surface. So phacoemulsification with little bit lowered parameters you should complete, because you don't want a lot of turbulence, because visibility is not good. You may not exactly appreciate the depth of PC. So there is high chances that you may damage the posterior capsule while doing cataract surgery or phacoemulsification in such patient. But however, in this patient, in spite of all the difficulties, because of this low and slow phaco and all the precautions, somehow I could manage to do a phacoemulsification. And this was the IA maneuver I am doing. And you have to be very careful. Even in IA also, I have seen people, they pull the bag completely and they land up in bag dialysis, because it's not their fault. Because of this light scattering by the corneal opacity, corneal haze, depth perception is really hampered. So you may be thinking you are below the capsular rim, but actually you will be exactly at the capsular rim plane. So staining the capsule and little bit go slow, and slow approach would help you in that. Always implant the bag in the bag if you are planning a dissect triple. My Dexis was of enough size, and if you can manage, then always try to aim for a little bit smaller size Rexes, maybe 5 mm, not 5.75. Okay, once the IOL is inside the bag, you have to use pilocarpine, because now we don't want to do anything below the iris. All the maneuver will be on the above the iris plane. So use pilocarpine. Yes, one more important thing: since you are using a lot of viscoelastic during phacoemulsification, you have to do a thorough IA. Why? Because if any viscostrand is there and that comes between your DSEC or DMEC graft and the cornea, then there will be a interface fluid or double entry chamber post-operatively, and which is very difficult to handle because some viscoelastic there. If it fluids, it may get absorbed. Okay, so you have to ensure that all the viscoelastic gone. Now, because of that longer duration phaco, you could see there was a little bit corneal burn. So it was a little bit gapping, so it was not self-sealing. So I would put a suture there. Then this is the artificial chamber. Nowadays, few surgeons, they don't use it. They simply do it with Halon field or air field, but I still prefer enter chamber AC maintainer while doing dissect. Now here I'm again trying to remove whatever viscoelastic there. I don't want any viscose strand in my enter chamber. So I'm using a bimanual to check each and every angle of my enter chamber so that no viscoelastic left. This is what I'm doing, a peripheral iridotomy. This is a cutter probe. You can see here I'm using a vitrectomy cutter to do a supernasal PI. Why PI? Because whenever I encounter some difficult cases, then I usually do a PI because I may be required to leave enter chamber almost 2/3 or more than that airfield. So I'll prefer to do a PI. Now this is decimal scoring. You all know how, if you have read about the DSEC, then this is an important step. You have to take out the hosts diseased or fibrous endothelial descemet complex. So this is, I'm using a reverse Sinski hoop. So first you make a 360-degree scoring. If you are not confident, you can use a marker, DSEC marker, which will give you 8 mm ring, and you can do scoring along that. This is, as you can see, this is the descemet membrane. This is descemet membrane and endothelial complex that has been removed. If you notice, I had used trypan glue. So first trypan glue for enter capsule. This trypan glue was to stem the endothelial complex. So this is the automated microkeratome assisted donor lenticle preparation that I am using here. You can see this is the 8 mm graft that I do. This is the side port. Normally, I preferred a corneocerebral tunnel for dissect and a supranasal or supratemporal quadrant. But here I have already made a 2.2 to 2.8 incision temporally. So I thought let's go ahead with this incision only and inject the graft. This is the Bushin glide where I am loading the dissect tissue, and I prefer to use a push and pull technique. So Bushin glide will be in, then I'll pull the graft in using intravitreal or crocodile forceps. So this is the Bushin glide with the graft, then you can pull the graft. And remember, all these cases, the cornea is hazy. So in these patients, it's always good to stay in the anterior aspect of your graft so that while holding the graft, you are not confused or you don't miss it. Okay, then this is the classic push and pull technique. And here you can see the glide is tucked in the tunnel and the graft is pulled in. After that, you can take out the AC maintainer and then inject some air, and by using a repeated stroking maneuver, you can center the graft. Since my incision is little bit towards the clear cornea, it's not going to self-seal. So I'll try to put a suture here. You can see here, I'll put a needle. I'll pass the suture. I'll not complete it. I'll complete it later on. I just need tamponade of that incision part. So I'll pass the needle and then I'll center the graft. This is my microscope integrated OCT, MIOCT. You can see here there is some little bit fluid between the host and my graft. So what I'll do is I'll do repeated stroking maneuver to take the graft to the center and then some repeated massage of the surface so that the fluid is gone. So this is repeated stroking so that the fluid is drained out of the interface area between the donor and the host, and the graft is little bit decentered. So in the end, by using this repeated stroking maneuvers, you can decrease the fluid gradually. And if you have a Merocil spear, you can use that also to do massage. Just do this for 8 to 10 minutes with a full AC8 tamponade. Usually the fluid, they go away. Even if little bit spaces are there, if you are using intraoperative OCT, then you can leave it like that because there are some donor irregularity. There may be some host irregularity on the posterior surface that will be shown in ASOCT as gaps, but that doesn't mean your graft is not attached. And I put a BCL because I had divided the entire epithelium to improve my visibility. Then I will complete my procedure. So things to remember when you are doing a triple procedure with endothelial keratoplasties, the visibility is the main issue. Okay, so use viscoelastic, epithelial debridement. You can reduce the light. You can use endoscopy or chandelier illumination and then complete the fix. Other triple with DALK, DMAC triple have done this. DMAC triple is very similar to DSEC triple that I showed that I just showed you. DALK triple, you remove the enter part, you reach the till the duas layer, and then you can do a phacoemulsification. Now, suprachoroidal hemorrhage, little bit of suprachoroidal hemorrhage. Remember all these open sky procedure, especially those optical triple PKP. The major concern is suprachoroidal hemorrhage and the intraoperative incidence of suprachoroidal hemorrhage. This for all surgeries like trap, glaucoma, everything is 0.29. For cataract is almost 0.03. For exactly for PKP, there are no such specific incidents, but it's somewhere between 0.2 or maybe 0.1. And these are the risk factors when you are operating a perforated corneal ulcer, like you are doing a therapeutic PKP, or you are taking a large size graft, or you are doing a combined surgery like valve with PKP or PKP with cataract, then the risk of suprachoroidal is high. You should always rule out these factors. If the patient is having this risk factor preoperatively, you have to counsel the patient. Your consent must mention suprachoroidal hemorrhage can occur. Like the most important is hypertension and arteriosclerosis. Remember, often people get confused that my hypertension is controlled. So, is there a chance of suprachoroidal? So, more than the pressure in the vessels, the problem with the wall of the vessels, your wall become less plastic or it becomes hard. So that becomes prone to rupture. So that is the main cause. So that is a risk factor. So even if somebody is having hypertension for a 20-year but control, still there is atherosclerosis or arteriosclerosis, the walls of the vessels are sclerosed, then there is a risk of expulsive hemorrhage, right? And this third thing, like advanced age. With age, also some sort of sclerosis of the vessels occur. So that is also another important risk factor. And this like increased venous pressure during Valsalva maneuver. When you're operating, it's a long procedure and the pressure in patient face is covered with towels. There is often a tendency to cough in old age patients. And because of the fear of you, they close their mouth, nose, and they cough within. That creates a sort of Valsalva maneuver. And this Valsalva maneuver can also lead to your uh, your suprachoroidal hemorrhage. So you have to counsel the patient before surgery to avoid all these things. If the patient is having some chronic cough, please control that before going ahead with the triple procedure. Then there are other risk factors, like especially those where the blood vessels are damaged or there is some hypercoagulable state, like blood coagulative disorders, hemodialysis, liver disease, thrombocytopenia, antiplatelet, anticoagulant medication, if the patient is on. These are also risk factors for suprachoroidal hemorrhage. Why this is important? Because once suprachoroidal happens, the patient will lose his eye in most of the time, and you are liable to go for medical legal cases for that. So if your consent clearly mention this, explaining this, why there is a risk and what can happen after that, then most likely you'll be safe because this is a known complication of penetrating keratoplasty. If you haven't mentioned this at all in your consent form, then you are liable to be sued by the patient, and the court may take a very negative view of that. You haven't explained the patient at all about the risk, right? So this is important because if the risk factor are there, you have to control that first. Then there are some ocular risk factors. Those are the systemic risk factor. Ocular risk factor, what you do during surgery, ocular hypotony. Remember, if you do a gradual hypotony, it's not going to cause suprachoroidal, but there is sudden hypotony. You are doing a manual trepanation and 360-degree full thickness trepanation was done. Then the pressure which was there inside the eye suddenly gone. So that will stimulate your that will lead to a separation of the suprachoroidal space with fluid accumulation, and then subsequently the vessels also they get ruptures. Okay, so that you have to avoid. Even if hypotony is there, it's had to be gradual. Uncontrolled high IOP. Patient is having because often in healed keratitis, measuring IOP is difficult. So you measure digitally or you simply write, okay, it appears normal. But you have to be extra careful about that. If the IOP is uncontrolled, you have to control it before going for a surgery. Then, if the patient has suprachoroidal hemorrhage in past, because I have seen such cases that I have highlighted. We had a patient from Shankar Netralaya. He had suprachoroidal in right eye, the other eye got operated here. Again, he had a suprachoroidal in the other eye also. So if one eye had a history of suprachoroidal, you have to be careful about operating in the other eye. History of trauma. In India, you get a lot of patients with history of trauma. And if that is there, your vessel might have already been damaged. So that is also a risk factor. Other than this, like these are some coincidental factors which have been associated with suprachoroidal hemorrhage, although some direct causal relation is not there, like hardness of the cataract, comorbidities, uveitis, intraocular malignancy, all this can also put the patient at risk of suprachoroidal hemorrhage. Now, if you're operating and suprachoroidal happens, then how are you going to manage? Remember, most of the cases is very difficult. Surgeon is often helpless. Once it starts, you cannot control it. The only thing is that these are the few things that you can try so as to minimize the damage. Okay, so you should always, the patient should have a IV line when you're operating triple procedure, and you should be ready with your monitor. The moment you feel that patient is having suprachoroidal, the patient will say immediately, I am having severe pain, and the glue will be altered. So these are the two danger signs of intraoperative suprachoroidal hemorrhage. If that is there, then please start IV mannitol immediately. Loosen your eyelid speculum because eyelid speculum also can increase the intraocular pressure, and the moment you put an incision, it suddenly collapses. The eye wall collapses. Lower systolic blood pressure. Even in one of our patients, we have to start IV nitroglycerin because it was a therapeutic PK and the patient's BP become very high during surgery and there was severe pain. So we thought it may be a suprachoroidal. So we had to start that. Once the bleeding has started, what you can do, few surgeons what they do, they put their thumb exactly on the globe to avoid everything coming out. They apply there for some time and they do repeat suturing, but it rarely helps. Then if some content has already been expulsed, then you can put them back if you have if you have achieved hypotony. Reform the entire chamber, and remember the most important is suture it as soon as possible. If and at times the pressure is so high, your 10-0 monofilament may break. So always keep a vehicle suture as backup. In one of my when I was a senior resident in one of my case, pediatric PK with a failed Peters, one of my consultant had supracorridor. And there we couldn't, 10 nylon was not holding at all. It was breaking. So you had to put 8 vehicle to fix to form the chamber and close the eye with the new graft. Okay, drainage sclerotomies, you need some degree of expertise in that. It's not difficult. You can practice that if you're a corneal surgeon, or if you have a backup of retinal surgeon, you can always call them. But remember, now it's very difficult to save a globe once supracortical starts, and prevention is always the best option for supracortical hemorrhage. Now, post-op care. Post-op care is similar to routine penetrating keratoplasty. I'm discussing a post-op care of a triple procedure. You have to give steroid, you have to give an antibiotic, you have to give lubricating drop. One important thing, remember, in triple procedure, the inflammation is more because you are doing cataract surgery. So there is likelihood that the IOP may be high for initial few days. So it's always a good practice to give some anti-glaucoma medication and stay vigilant for any IOP rise. From the patient perspective, if you do a triple procedure, is there a chance of increased graft rejection? Well, the answer is controversial. There are no clear-cut evidence suggesting that if you do a triple procedure, there is a chances of increased graft rejection. However, this is a review article we published last year. And while if you see this image from that article, high risk factor inflammation, right? So if you are doing only keratoplasty and somebody is doing keratoplasty plus cataract surgery, then definitely the amount of inflammation with triple procedure is more. So theoretically, if you are doing a triple procedure, the patient is highly likely the chances of getting a graft rejection may be more. But with modern day steroids, immediate control of inflammation, it appears less. That's why in most of the clinical study, there is no clear-cut evidence suggesting triple procedure to increase graft rejection. If the patient asks you, is it going to hamper my graft survivability? Then answer is no. Now, just the last slide. So why triple then? When all these risks are there, like suprachoroidal risk is there, everything is there, why to go for triple? First do a penetrating keratoplasty and then do a cataract surgery after that. Once you have a clear graft, then do a closed chamber procedure. Well, it sounds really great. But you know, in India, it may not cost that much. But if you go to Western country, if you have to admit patient twice, the cost is too much. So that's why a lot of patients, they prefer a single visit rather than two visit to the OR for surgery. So that is the most important factor. And second, when the cornea age is significant and the cataract is also significant, if you do a keratoplasty only, the patient is not going to be happy. The patient says, "मुझे तो कुछ vision आया ही नहीं." है ना? So that's why triple procedure is done when the cataract and cornea both are significant. And if in one of the interviews there in YouTube, you could see there is a famous surgeon who says, if I feel my cataract is significant, I'll go for triple. If I feel that my cataract is not significant, I'll go for a stage procedure. In my approach also, most of the DSEC we have shifted to stage 1. We don't do triple. But for PKP cases, we still do triple procedure a lot of time. For triple procedure, the problem is visual acuity, but it's a kind of it's both way, you can say, because if you do a stage procedure, right, the final vision that the patient is going to get will be better. Why? Because first you did a penetrating graft, then you know the keratometry. So when you're doing a cataract surgery, you know the keratometry, you can plan a toric IOL. So the final vision that the patient is going to get is better in stage. But if you ask about day one vision, triple procedure is better because you have changed the cataract, you have removed the cataract, and you have changed the cornea. The day one visit will be better for triple procedure. Now, IL power calculation accuracy. Yes, of course, in triple it's poor because you don't know what is your final K, what will be your final keratometry. No, you are not sure about the axial length. So the IL that you are putting at times it's not accurate or it's not perfect. But in stage, yes, you can plan. And in fact, when you are doing a dissect, there is a tendency of hyperopic set. So you can plan your IOL like minus 0.5 or -1 myopic, so that can be adjusted later on. Complication again in triple, the complication high because it's an open sky procedure, but in stage it's less. So indication only if you should go for triple when the cataract is significant, or the patient demands that. Patient says, no, I don't want to come twice. I just want to go for surgery once, and please do all the procedure in one go. So then only you should go for a triple procedure. I think with this, I will conclude here. I hope you people understood something, some of the nitty-gritty. But from exam perspective, triple procedure is it's not like a very, very important topic. However, you can get it as a short case or in surgery viva. Somebody may ask you. Or in long cases, if you get a case of healed keratitis cataract, then the viva may go towards triple procedure. So few of the salient point and few of the point about suprachoroidal hemorrhage you should remember, and that will help you in your exam. With this, I'll conclude here. Thank you, everyone.
Thank you very much, Dr. Prafulla. I think that was a very informative talk. Dr. Bhupesh, do you have any comments?
I think I must compliment Dr. Prafulla for a very illustrated talk on this topic. And this is such a vast topic that, for PG, probably this is, whatever he has covered it encompasses most of the things. Just want to share a few things. It looks very easy. When we were resident, we used to see open sky. We used to think that, cataract is such easy, and, doing IA would be with the Simco will be very easy. So, the harder the cataract, the better it is while you're doing a triple, because, then you don't have to do a cortical wash, because cortical wash is one which actually is the main pain in the cataract extraction, because that takes the maximum time, and most of the time the PC is just tinted up and it is convex up, and then very difficult to remove. Secondly, I would say one more consideration for triple would be, like, in most of the cases that we see, you see a patient who's got an adherent glaucoma. Now here, that the anatomy of the AC is shallow, the anatomy of the, that there will be definitely a lenticular corneal touch, and the iris also would be very misbehaving in those cases, it will not be dilating. So here again, we don't have any other option but to go for a triple procedure, because where the AC is also not uniform, then definitely that primary only you have to go for a triple procedure. But in case if you can, as Dr. Prafulla brought out, in PK with the cataract, especially if the patient is more aged, then definitely triple is the way to go. And in case if you can go for a stage procedure for a Fuchs or a likely endothelitis, viral endothelitis, then probably, yes, you can plan a staged.
Yeah. So I think Dr. Prafulla has covered quite a bit. I think, yeah, he wants to reply, sir. Do you have any comments, Dr.
Just
Prafulla?
to add on to what Professor said, if you are in the decision-making stage, any patient with corneal opacity where you are not able to visualize the lens, please plan a triple. Even if you may change the decision intraoperatively, but keep an IOL on backup, because you never know when you may require to put an IOL.
Right.
Thank you.
So basically, in my experience, while I was training in Shankar Nethralaya in Chennai, of course, we used to do a lot of triple procedures. Our protocol was always to do an IOL power calculation on the pentacam, sir. By and large, we used to take the keratometry readings from the central 3 mm and try to do it. And sometimes when we were not able to do it, we would try to calculate the IOL power from the other eye, from the fellow eye, considering, because sometimes, that is the best possible way to be able to calculate the IOL. As a protocol, what I do in my practice here in Center for Sight, Banjara Hills, is because most of my patients are of a different strata, and so I generally tend to go for an IV sedation along with a peribulbar block. That makes the patient more comfortable. As Dr. Prafulla said, GA nowadays is not my preferred choice, but sometimes if I feel the patient is very anxious and may not cooperate, I do an IV sedation along with the peribulbar. I think another thing, because I made certain observations, my points while he was speaking. So I think vacuum trephination is what I routinely do, Dr. Prafulla. I used to do manual trephination during my fellowship, but of course we do manual trephination. It's much more controlled. And as he said, there is no sudden hypotony, because you can control and not go full thickness. Because any full thickness can lead to, there are the chances of of suprachoroidal increases, but also the chances of lens expulsion increases. In some of my cases, I've seen if you go full thickness, you actually hit onto the iris and suddenly the lens starts to expulse, becomes very difficult to control. One thing which I wanted to ask Dr. Prafull, during his talk is, I find some cases where I've done triple with posterior cynic, and the lens is nicely adhered onto the iris is adhered onto the lens. So, do you use iris hooks during these cases? I mean, how do you proceed in these cases where you have posterior cynic with the lens? So you do an open sky and then use iris hooks, or you do
In open sky?
or you just use the Cook hooks to manually stretch the iris and remove the lens?
Normally we do that because iris hook, I don't think it
It's
will take
needed
a lot of time first.
Correct. No, I've been
And
because,
truly speaking, I've never tried iris hook, but I don't know how it is going to work because again, it's an open sky procedure. There is nothing in entry chamber to push the iris hooks down. Okay, so it may
technically,
not work. Or
the iris hooks, yeah, I use the Cook hooks to
So-
mechanically dilate the iris. But I recently saw
mechanically
a
dilate
video on
that is
I recently saw Dr. Uday Devgan's video on where he was doing an open scan using iris hooks after doing the trephination, which I thought I'll put it up for discussion.
So Dr. Varun, I'll just like to add on this. So,
Please,
what happens is, as you said, the first thing I would say is I like to break the synechia with the help of your normal visco cannula and try to see if the pupil is stretching, if the iris is stretching enough for me to remove the cataract, to see the axis of the cataract and remove it. Now, what happens is that in some cases, especially in adherent leukomas, the iris is so floppy and it has got such a bad memory that it will just not open up. So it will be like 3 millimeter pupil, 3.5 millimeter pupil. So as you rightly said, I have used B-hex ring also. So you can use a B-hex ring, you can use a Malusian ring, and it gives, in fact, it helps in managing the cataract also because it gives something against the positive pressure of the vitreous also. Because it really stretches the iris and then it gives you that counter pressure which you require.
And you insert these pupil expanders once you have done the trephination and remove the contact.
Yes. So you can use easily. You can use, so there you don't have to use the injector. So like if you are using a BX ring, you just use two instruments. Basically, you use McPherson forceps or a suture tying forceps and gently insert it. It very beautifully goes in, and then it allows you to remove the cataract and do the cortical IA and implant the lens, and then subsequently you can remove it and finish off your keratoplasty. Even with Malusian ring also you can do it.
Interesting. As Dr. Prafull's video on the DSEC with phaco was excellent. I found the video very interesting. It was fantastic. Very nicely done surgery. Dr. Prafull, in your experience, when you do the DSEC, because in the video I found that there was a fair amount of corneal opacity. And once we have done the endothelial keratoplasty, do you feel that the stromal opacity also reduces? I mean, what has been your experience?
No, our patient profile is more like patient, they don't have that much, what would say, this social status says that if you do the full thickness graft, you're not sure about that follow-up or anything. So that was a one-eyed patient. And the scar was mostly informing the inferior 6 mm area. So our target was just go get with the endothelial keratoplasty. Even if the superior cornea is clear, if she has some good vision, then she can manage. That was the thought process. But ideally, during surgery, I realized I should have planned a TKP in this patient. Because doing cataract was a nightmare for me in that patient.
No, but actually there has been a paper recently by the SNEC group by Dr. Donald Tan et al. In which they say that, where if you do endothelial keratoplasty with very, minimal stromal opacities, the stromal opacities tends to reduce and the cornea becomes clearer. Well, I have not made these observations myself, but there's a paper to that effect.
One thing important is the duration of edema. If your corneal edema is not there for a very prolonged time, then the scar clears, especially if it is due to a herpetic cause.
Correct.
But if it is due to healed keratitis, it's not going to improve. For example, bacterial keratitis, fungal keratitis, the scar doesn't improve. But if it is due to herpetic cause, we have also seen in few patients, it clears.
There has been a question by one of the students, Dr. Praful, for you. Do you feel that the DMAC triple is more controlled as compared to a DSEC triple?
Trolled. Is it a social media troll or what?
No, no. There is a student who has asked you a question. I mean, somebody who was attending this class has put up a question.
Elaborate. DMAC which is better.
Yeah.
Okay.
So,
Yes. So DMAC triple, if you can do it, if you have that expertise, then it's always better, I would say, because nowadays everybody believes that DMAC is better. But if you don't have the expertise, or if your cataract surgery is very challenging, it's a very difficult one, you have hit the iris, you have released a lot of fibrin, in those cases, or you have landed up in some complication like vitreous loss. In those cases, I would avoid a DMAC triple. I'll go for a DSEC triple, which is more predictable for me. DMAC triple, yes, it's a clean case. Corneal clarity is good enough. It's a hardly struggle while doing cataract surgery. There is not much fibrin release. Then I will go for a DMAC triple. So if condition, it depends on the condition that you encounter during cataract surgery. Challenging
Okay.
cases, long surgery, fibrin loss, hit, always go for DSEC triple. And second question is also, can suprachoroidal occur after DSEC? Yes, surprisingly, you won't believe the review article that I had quoted. They found that the incidence of suprachoroidal following DSEC is more than PKP. However, it was a very small study. But theoretically, if you compare PKP versus DSEC, DSEC is a more like a closed chamber procedure like cataract surgery. So at RP center, we haven't seen any suprachoroidal with DSEC till now. But there are reports in literature. If examiner asks you, you have to say yes. If there is a possibility, people have reported. But the chances are less compared to PKP.
Well, Dr. Ishita, to answer that, I think Dr. Praful has answered this question in detail. What I personally feel is that theoretically speaking, a DMAC triple would give better outcome, but it's a much more surgically challenging procedure. I have never had the guts to do it. I have always done it in a stage procedure, to be honest. So I do the cataract and then wait and then do a DMAC as a second stage. I have never tried it, to be honest. I have never had the guts to do it. I think Dr. Bhupesh can throw some light on it. What do you feel, sir?
Yeah, so basically, unless you have an absolutely clear cornea with only diseased endothelium, DMAC triple would be very difficult to do. Even if you have little stromal edema also, it's very difficult to visualize this thing and very difficult to manipulate the graph there. So rather, in such a scenario, DSEC would definitely be the procedure of choice, because there once you have pulled in the graph, the orientation and you are very sure about this thing. So I think visually both of them are okay for the patient, whichever one we can do. But for a surgeon, definitely DMAC triple would be rather limited in as far as we can offer to the patient as compared to a DSEC.
Dr. Praful, do you also make venting incisions while you are doing an endothelial keratoplasty? Because you said that there can be trapped visco and fluid sometimes, and do you feel these venting incisions will allow it to seep through?
We have stopped doing that after we got this microscope integrated OCT. But for beginners, and if you are not sure, venting incision is quite handy. Always be done, especially in complicated cases or difficult cases like this where you are not sure. Then in those cases, you should go ahead with that. But if you have some intraoperative imaging or you are 100% sure that my graph is well attached with that double ring sign, then you can leave it. But if you're doing that, it's not a
yeah, so generally, if I'm doing it in aphakic cases, I generally tend to do venting incisions because, anyways, attaching the lenticle is more difficult. But yeah,
5-6 years before we used to do that. Now we have stopped because mostly OCT gives us that image and we are sure that okay, graph is attached.
Actually, we don't have
We are not doing now.
Yeah, so even I don't use any venting. I don't give any venting incision in any of the DSEC cases.
So post-operatively, as you said, since you are doing a triple procedure wherein you are combining a PKP with a cataract and there is more chance of inflammation, how long would you continue topical steroids? What would be your and how would you taper it?
Is it a question for me?
For actually both of you, sir. Both of you.
Okay.
Okay, because okay, so the question is how about the steroid tapering? If I've done a triple procedure, my initial 4 week will be like cataract surgery. My steroids will be initially maybe too early, then 6 times. Okay, but after that I'll taper it gradually. After 1 week is done, then for 1 month it may be 4 times. Then next 1 month maybe 3 times. The next 1 month, so gradual taper. But initial 1 week I'll treat it like a cataract, like initially high steroids and then gradually taper it down. But if I do a standard PKP only, I'll give only 4 times a steroid, 4 times a day. That is good enough.
Dr. Bhupesh, what's
So
your
my
And
for both
anti-glaucoma I
the
routinely give for first week.
so along with systemic steroid, as far as topical steroids are concerned, I like to taper it over a period of 2 to 2.5 months. And I normally maintain the patients for twice BD dosage for at least a year, unless it's a DSEC case. In case of a full thickness, definitely you require, because in between you definitely be going in and doing suture removal, where again you will be stepping up the steroids. So largely I don't want the patient to be off steroids. So the patient will come to the maintenance dosage of twice BD after a period of say 8 to 10 weeks. And subsequently, whenever any steps has been done, largely the suture removal, suture change, suture exchange or whatever, then I'll strap it up and then again bring it down.
Sir,
Yeah,
any
1 year
indications for
steroid.
oral steroids, sir? I mean, do you start oral steroids in any of
I
these?
give oral steroids for OPKs in all cases, either a simple OPK or even for a triple procedure. Definitely
Oral steroids for all cases, sir.
for 4 weeks. Yes, for all cases.
What about you, Dr. Prafulla? What have you been doing, sir?
Don't prefer oral steroid in all cases, but if yes, I feel inflammation in very, or I have during surgery I have done some iris manipulation, some pupilloplasty. In those cases, I would definitely go for a oral steroid. If it appears as if it's a uneventful triple procedure without much difficulties or much manipulation, then topical steroid may be starting too early, and at the end of month keeping it as 4 to 6 times. I would prefer that. So I don't give oral steroid routinely. But if you go through the literature, there are conflicting reports. Few surgeons have claimed that if you give oral steroid, it definitely reduces the incidence of graft rejection. There are few reports which suggest no, it's not useful, but it all depends on your expertise. If you feel that inflammation is high and there are no contraindications for oral steroid, then there is no harm in giving oral steroid.
And immunosuppression in failed grafts, sir? All fail if you're doing a PKP2.
All high risk graft we are now.
Yes.
Yes.
So same for all, I mean, regrafts, highly vascularized grafts, for those grade 5, poor prognosis grafts. So basically, mycophenolate it definitely helps. And so typical would be you put the patient on steroids, taper it over a period of 4 weeks, and you step up in the meantime, you add the patient on mycophenolate so that the mycophenolate then takes over, and then at least for 6 months. So that is what I normally do, at least for 6 months. And it's pretty safe. MMF is pretty safe in the sense.
And anyways, I think you must be following the patient up with the rheumatologist also, since you have put them on immunosuppression, right?
Yes, definitely.
And nowadays,
Get a rheumatology review, definitely. But what at AIIMS, what we have realized, even our rheumatologists, they also call us and they say that no need to send us for that. You can just keep on checking the LFT, and CBC. If you find there is any problem, then you send it to us. If all the parameters are going okay, no need to send the patient to rheumatologist. You just continue with the dose.
and sir, any role of topical cyclosporins in your PKP?
If it is to me, then my if your patient is not not a steroid responder, then I don't think cyclosporin has any role at all. However, if your steroid patient is steroid intolerant, patient is getting steroid induced glaucoma, then I think you have to resort to cyclosporin only. Whether it works or not, I don't know. Frankly speaking, in few cases it works, in few cases it doesn't work. But as a steroid alternative, we don't have much choice. We have to give cyclosporin only. But if my patient is comfortable with steroid, I won't go for cyclosporine. I'll continue steroid only.
Dr. Bhupesh?
I think one indication of adding cyclosporine to your steroids would be in case if there is a secondary indication, as in like a patient having a dry eye, so if he's going to benefit with cyclosporine, I mean, what I mean to say is a patient of RA having, or a patient of some of the other immune conditions where definitely cyclosporine would definitely help in controlling the inflammation and preserving the T glands. So there definitely one can add, but then those subset of patients would normally be practically be pretty less.
So basically what since we used to do a lot of ocular surface work in SN with Dr. Geeta, and we used to get a lot of patients of chemical injuries. So what the protocol we were following there is, if we were doing a transplant in cases where there were OSD disorders, like it was post a chemical injury, and as you said, very severe dry, we were putting them on very long-term cyclosporins for 6 months approximately, along with omega-3 fatty acids, and probably this was the only indication for us. Wherein we would, but anyways, there is no substitute to a steroid. We would obviously put the patient on topical steroids. And then, once it tapers off and we reach a level where it is only 3 times per day for a month, and that is when we would start the cyclosporine as well, because it does tend to, papers say that it tends to, make the ocular surface a little better.
So unless there is an ongoing, yeah.
Yeah, please.
So basically,
so we did a study at RPC Center about cyclosporine, and we used 2% cyclosporine. That was a custom-made preparation from our ocular pharmacy.
Right.
And in that study, there was no difference in graft rejection evidence. But one interesting fact was that if you start patient on cyclosporine, the interval between 2 rejection episodes, that was significantly more. Means the episodes of rejection, the duration was more in cyclosporine group compared to only steroid group. Steroid patients were getting rejection at a lesser frequency, less time. For example, maybe 30 days. But if you add cyclosporine, 30 days become like 45 days for episode of graft rejection. So it works, but how much it works, I don't think. Maybe some ongoing study, they will come out with some answer to that.
So I thank both Dr. Prafull for his wonderful talk and Dr. Bhupesh for his excellent contribution and in the points he's put forward. I think we've run out of time. It's already 9 o'clock, and I'm sure the postgraduates would have benefited a lot. I personally benefited a lot with this discussion, and I thank both of you. Thank you so much, sir. Thank you.
Thank you.